I will post later on, which is going to be alveolar and vascular. Okay, so this is half of it. So, pulmonary patterns. The reason why we do pulmonary patterns is the goal is to find out or identify in which compartment of the lungs or thorax the disease is. So now we are primarily talking about lungs. So we'll focus on the lungs. So it's either the airways, which can be diseased, which means the trachea, the main stem bronchus, the secondary tertiary bronchus, and then bronchioles. So either the airways are affected, or the alveoli is affected, or the interstitium is affected. So interstitium is the connective tissue which is in between the airways and blood vessels. That's your interstitium or connective tissue, right? And vascular is when the blood vessels are affected. So our goal when we are looking at a radiograph is to identify which compartment of the lungs is actually affected. And we take help of these patterns. Patterns are nothing but some features which you are looking for. Okay? So the four major patterns are bronchial, interstitial, alveolar, and vascular, depending upon what is affected. So bronchial means the disease is in the airways. Interstitial means the disease is in the interstitium, which is outside the airways, in the connective tissue, or parenchyma, it's the same thing. Now interstitial pattern can be structured or unstructured. So we divide it into two broad categories, structured, unstructured. Okay? Alveolar is if the disease is in the alveoli. Vascular if the vessels are bigger than normal or smaller than normal. If they are smaller than normal, we call this a hypovascular lung field. But the pattern is still vascular pattern. And if they are bigger, then you can say there is a hypervascular lung field. And if the vessels are smaller, you will say there is a hypovascular lung field. But for either of the case, the pattern is still vascular. Good? Alright, so let's start with the bronchial. So the radiographic findings for bronchial are thickening of the bronchial walls, or there could be calcification of the bronchial cartilage. So you can easily identify the walls of the bronchi or bronchioles. And calcification can happen because of old age. So if you see calcified bronchial cartilages, it's still bronchial, but it's just an incidental finding if there are no clinical signs. Okay? And cellular infiltrates outside the bronchi. This is called peribronchial cuffing. So remember, when I talk about patterns, it's not that if it's bronchial, you will just see the bronchial. Remember the anatomy, everything is interconnected. Even if the disease is in the bronchi, it will eventually reach interstitium, and eventually it can go to blood vessels. So it's spreading. It's just not localized to one compartment. But we are trying to pick up the most prominent diseased compartment of the lung. So our goal is to find out what am I treating, the airways or alveolar disease or interstitium. That's the goal. But it doesn't always mean there will be just one pattern. It could be a mixed pattern. There could be multiple compartments affected. Okay? But we will try to focus on identifying the most prominent one. Alright, so bronchial pattern, the radiographic findings are donuts or tram lines. So what are donuts and what are tram lines? So donuts are actually circular radio opacities that you will visualize, which are actually end-on airways. And tram lines are longitudinal airways, so it depends upon how you catch them on the radiographs. Because remember how the trachea and the bronchi, they branch into all different directions, right? It's not one direction. So when the patient is lying on the table in the lateral recumbency, some of the bronchi and bronchioles will be pointing towards you, end on. End on is like, for example, this is the pen, this is longitudinal, and if you're looking at it like that, that's end on. Okay? So some of the bronchi you will capture like this, but some of them will be captured like this. So those that get captured like this on the radiograph, they will show up as tram lines. And those that captured like this, you will see donors. Clear? Okay. So let's take a look at this one. This is a drawing, and I believe Dr. Perry made this. I'm not sure, but I got this from her. So this is an airway, and the darker lines here, this is representing thickening of the bronchi or airways, which could be inflammation like bronchitis, or it could be mucus formation, which is lying on the side of the walls. So something is causing thickening of the walls. So these will be referred to as tram lines. And then when you see these tram lines end on, then they look like donors. So it's the same thing, just a different how you capture them. Okay? So tram lines, sometimes you will see that both sides are thickened, and sometimes only one side is affected, and we call this monorails. Monorails are very rare, because usually it's tram like this. If it's in the human, it's affecting both sides, usually. Okay? And peribronchial cuffing, it means when the opacity is spreading around the bronchi. So the disease started in the bronchi, but now it is also spreading in the interstitium. So some people refer to these as donors, and then peribronchial cuffing as bagels, because they are more fluffier. So it's up to you how you want to remember these. But the point is, the disease is more confined to airways here as compared to peribronchial cuffing, where the disease is also spreading in the interstitium. Okay? Any questions? Alright, so this is another representation of bronchial pattern. So this is the trachea, and then it divides into branches. This is the left side, so left cranial, left caudal, and then the left cranial divides into further cranial subsegment and caudal subsegment. Okay, and remember 4 lobes on the right side. So one branch of the airway goes to the right cranial, right middle, right caudal, right accessory. Okay, and this is just a representation of thickening of the walls. So you see tram lines and you see these donors. So it doesn't matter if the patient is in the lateral recumbency or a BD or a DV, you will see both tram lines and donors on both the views. It's not like one is more prominent on one view. Okay? And donors are more easier to find than tram lines. Alright, so this is an example. This is a drawing where you can see how donors look like, and then this is a representation of a tram line. And this is the actual radiograph. So just try to identify different donors, like here is one, and here is one, and then here you can see one. There are multiple donors that you can identify. Here is one. Okay, good. So, but we do know that there will be branching of the trachea at the carina, right? So you will always see some donors in the region of the carina, but just seeing a couple of donors does not make it a bronchial pattern, because you will see some normal branching as well. Okay? It doesn't always mean disease. But when you see a lot of donors, especially towards the periphery of the lungs, like in this area, and also up in this area. So if you see donors in the periphery of the lungs, then most likely it is a disease pattern. It is bronchial pattern. Okay? And then also correlate with the clinical signs. Okay? And there is a difference between the conventional radiography and digital. So most of the clinics have digital radiography now. In those, the quality of the radiographs is very good. And sometimes these donors are so clear that you will see some donors in normal pets. So seeing donors doesn't always mean disease. But the key is, if you see donors in the periphery and the dog is coughing, then most likely it is a bronchial pattern. So there is a tendency to over-interpret bronchial pattern. So just watch out that some donors are okay, they are normal. Okay, and then that comes with practice, like how many donors are normal. A couple of them, like maybe five donors, 10 donors you see near the carina, that's okay. But seeing them in the periphery is not normal. Okay? So in this presentation, we have included multiple examples just to clarify the patterns, because students struggle with that. So just bear with me, I'm going to go over multiple examples. This is the same picture that I showed you in the last slide, but this is a different example. So you see these donors clearly. So I see them in the carina, yes, and that could be normal, but I do also see them in the periphery. And they appear more subtle. The reason is because the size of the bronchi will be narrow towards the periphery. So they will be more difficult to visualize because they are smaller in size, but if you see them, that's abnormal. So always focus on the periphery when you are looking for bronchial pattern. Anybody who is having difficulty seeing the donors? Okay.
Question.
Yep, question.
Can you point out the donors? I can see some like, in the main ones, but I can't see.
In the periphery? Okay.
It's better on your computer too.
So also see on your laptop if that makes it better, I'm not sure. So for example, here is a one teeny tiny donut. There is a one donut here. There is one donut here. There is one donut here. Yep.
Alright, so I may have missed it because I'm still waiting for mine to download.
Yeah.
Are the railroad, or the train tracks like the bronchioles and the donuts like the alveoli? Is that whatever? Okay.
They are the bronchioles.
Oh, just going this
Bronchi
way
and
instead of
bronchioles.
this. Got it, okay.
So we cannot see individual alveoli on radiographs unless there is emphysema and a bunch of alveoli come together, then you will see some lesion. But normally you should not be able to identify alveoli. Okay? Next question.
Can you pull out the tracks?
Mhm. So for example, for tram lines, look at this one. Can you see this radio-opaque line? And then you see another up here, the ventral one is more prominent than the dorsal, but it's there. So that would be a tram line. Okay? So it looks very clear on the picture, but when you look at the actual radiograph, you really have to look into it. Where is it? Okay? With practice, you will get there. And we'll show you a lot of examples when you come to rotation. Question? The donuts again? Sure. That's fine. So here is one. There's one here in the periphery. There's one here. I can see some here. And then 1, 2, 3, 4, 5. And then there are a lot of them here. You can easily identify these ones. Right? Good? Any other question? Alright, so this is how a bronchial pattern looks like. So see for yourself, can you identify them? Tell me if you are not able to see them and I can point them to you. Anybody having difficulty?
The railroad track?
Railroad tracks? Sure. So, see this one? See that line? Radio-opaque line? And then there is another radio-opaque line going up here. So that would be a railroad track. And the same thing here. And then the same thing here. So you see how donors are more prominent than the tram lines. I mean, you can still identify tram lines. And then on this example, you can see the tram lines here, here, here. Question?
And so we keep going. So how do you differentiate those donuts from the bagels to the same?
I think we have a slide, so maybe on this one, look at this donor here. And look at this donor here as compared to these donors. Do you see the difference between this versus maybe these ones? So this one is more radio-opaque at the periphery as compared to the others. So I may call that one a bagel. Like maybe from this bronchi, the disease is now going into the interstitium. It's just very subjective. Question?
Can you bring up the bagel again?
Yep. So this one right here, see how it has more fluff around the periphery, which means there is more radiopacity at the periphery of the airway, which is a bagel. So bagel and donors, these are just for learning. I would advise you not to use those maybe with the clients or what? Donors and bagels in thorax, so it's just for learning purpose. Question?
If we see a lot though, does the kind of words like saying bronchointerstitial or?
Yeah, some people use that.
Okay.
Bronchointerstitial, not every radiologist like that term, but it's very commonly used. Many radiologists will use bronchointerstitial. Yep. Any other question? Good? All right. So you can, do this exercise at home as well. When you are reviewing the PowerPoint, just make sure you can identify donors and tram lines. If you are having difficulty, you can always send me an email and we can set up a time. So here we are pointing out some donors and tram lines for you. So look at the tram line here. Easily identifiable, right? So you can see the radio-opaque line on both sides. So if the patient is coughing and there is wheezing, then I'm going to say that this is most likely a bronchial pattern and not calcification. But sometimes in older dogs who are asymptomatic, this can appear due to calcification, which is incidental finding. Okay? So always correlate with your clinical signs and age. Question?
So is it the trend lines are going down, like they're not going,
Instead of saying down, what?
or they're going caudal?
Caudal.
Okay.
Caudal. Good job. Yep.
Okay.
Good? All right. Question, sorry.
In terms of your donuts and bagels, if you don't see that radiolucency in the middle in the lumen, how are we going to distinguish that from mets?
From
Like
metastasis?
metastasis?
Did everybody hear the question?
No.
So the question is, if the lumen of the bronchus is completely filled with mucus maybe, it's going to look more radio-opaque, like a radio-opaque structure, right? So how do you know that's not a metastatic nodule? Pardon me? The size of it?
It doesn't have margin. If it was a nodule, it would have margin, but a lot of time.
Well, look at the bronchus, it also has margins, right?
Well, would it neoplasia that's abnormal, like not clear margins?
Yeah, usually the metastatic nodules will not have a clear margin like the bronchus does. And it's not going to be as opaque as the bronchus will look like. The metastatic nodules are very less dense as compared to the mucus-filled bronchus. And they do not have a clear margin usually. And you can also identify the location. Like for example, if I'm looking at a bronchus here, I know there is a branch of bronchus in this location. But if you are concerned about a metastatic nodule, what can you do? Well, even we reach the biopsy, that's for sure gold standard. I'm hearing abdominal rats. If there is like a mass-like structure which you can take another view. You can take abdominal rats to see if there is a bigger mass in the abdomen which is causing metastasis. Or you can just repeat radiographs in maybe a week or so. If it was a true metastatic nodule, it will grow bigger. And a week is enough time for a metastatic nodule to grow bigger. If it was a true bronchus, it's gonna stay the same size. That's the easiest thing that you can do. Okay? Any other questions? But that's a common dilemma, like sometimes it's unclear if it's a metastatic nodule or not, and we just recommend them to come back in like a week's time, if we cannot find the primary neoplasia. All right, good job. So, feline asthma is another example where you will see the donors and tram lines. But you have to be careful with cats because the donors and tram lines are not as prominent as you will see in dogs. It's going to be very subtle. Very subtle. So for example, look at these two radiographs. There are donors in these two. But see how different they look than the dogs? They're very subtle. Okay? But if you look carefully, they are throughout this area, throughout the chordodorsal lung field, in both of these. Okay? And also in feline asthma, a very common sign exists, which is called a lobar sign, and I will talk about lobar sign again later on. But you see this radio-opaque line from the carina to the apex of the heart? See that sharp radio-opaque line? That is called a lobar sign, and which is just appearing because the right middle lung lobe is collapsed. Can I do that one more time, please? Try to see it for yourself. So there is a sharp radio-opaque line starting from the carina